my history is coming into age management as a career in anesthesia, which is really a backdoor to what I do here. The good thing is that I grew up, as Dr. Willis has said, that with this background of yoga and martial arts and meditation and calming. Coming into age management has been phenomenal in my life personally and in the way that I'm able to treat patients and use my experience with them. What I found interesting is having a few patients that had rheumatoid diseases, autoimmune diseases in my age management practice, which that's not my mode of treatment. That's not something I do every day. But it did spur me to look about these diseases because in my age management practice, we're looking at telomeres. We're trying to understand aging process, what happens with shortening telomeres, and how we can interact in any direction to improve that and lower their risk for disease and improve their lives. This is basically over-exaggeration of what happens with telomeres, but you can see the sneaker on the right is beautiful. It's been preserved. The nibs or telomeres are all intact, and this is what happens when we don't take care of our telomeres. The question is, how do those telomeres interact with some of these diseases that we're seeing in our patients? There was a wonderful article that kind of went over all this stuff, stuff that we hadn't thought of, and it's very well referenced at the end. If you need anything, I can give you all these references. Again, what we're getting down to is effectors of autoimmune disease. Why does our body attack itself? Is it a change in the attack cells that allow them to proliferate and attack it, or is it a loss of suppressor cell function? Both, of course, are important. And how do we deal with that? How do we prevent telomere loss and affect these things? And I think that'll come on later with other speakers and in the panel at the end. Okay, just basic science. Telomeres, tandem repeats of TT, A, G, 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 the nucleic acids. We're protecting chromosomes from DNA degradation and end fusions. Every time a cell divides, we lose telomeres. For some reason, cells divide more often than others, and some abnormal situations, we're seeing a tremendous amount of cell division. That net cell division ends up in shortening of the telomeres. As conventional DNA polymerases are unable to fully replicate the ends of the DNA molecule. Telomerase, of course, is that enzyme that adds the telometric ends onto the chromosomal ends, and this compensates for those losses we see with cell division. Telomerase negative cells exhibit shortening telomeres until a critical size known as the mortality 1 checkpoint activation happens. That results in cell senescence. In these cells, we can see that telomere length determines the replication of the cells. Genes control the replication of these cells. In the case of their inactivation, these cells will continue to divide with persistent erosions of these telomeres until the DNA breaks. Recombination occurs, or we get end fusion on these DNA. This point is what we call the mortality 2 checkpoint. This is cell death or apoptosis. There have been rare culture cells that have been able to circumvent this apoptosis, this M2, and become immortalized by a reactivation of a telomerase enzyme or by a recombination-based mechanism to maintain their telomere length. Autoimmune and inflammatory diseases are characterized by a hyperactivity of the immune system. So this immune system and autoantibody production and associates itself with inflammation and oxidative stress. This is where our interaction probably is going to come. Inflammation, oxidative stress, and increased leukocyte renewal, as we said before, describe the environment seen in the acceleration of this telometric shortening. And this suggests there's a connection between the system and the autoimmune and inflammatory diseases. Just a few of the diseases, if we look at them and break them down into individual components and what happens in them. In systemic lupus erythematosus, we see telomere length in the peripheral blood mononuclear cells. We especially see this in young patients. In these patients, just the same, we see higher telomerase activity. When we look at rheumatoid arthritis, we see telomere length decreasing in these cells independent of the severity of the duration of disease. So one's normal assumption would be that, oh, this guy must have terrible telomere because his disease is terrible. It's not true. So it appears to be that there's a factor there independent of whatever's going on with that disease process. And in both of these, of course, we see higher telomerase activity. This is the article done showing that, and the conclusion was that the reduced TRF length in a group of patients with rheumatoid arthritis compared with controls has been shown. The reduction is apparently independent of disease duration and markers of disease severity, but is influenced by HLA genotype. And we know HLA genotype is something that's very important in all these diseases and links all of them together. Another article from United Kingdom: the immune system is equipped with an extremely large spectrum of structurally diverse receptors to recognize all potential antigens. This fundamental principle of receptor density is no longer upheld in patients with rheumatoid arthritis who have a marked contraction of their T-cell repertoire, their receptor repertoire, excuse me. In this study, the ability of rheumatoid arthritis patients to produce T-cells and to maintain T-cell homeostasis was looked at. The CD4 T-cells, if you remember, these are the T helper cells containing T receptor rearrangement excision circles, were substantially reduced in these patients. And Treg, that same excision circles levels in young adult patients, matched those of controls 20 years older. Wegener's and sarcoidosis, we see telemetric, again, erosion in the peripheral blood mononuclear cells in long-term disease with Wegener's granulomatosis. There was no telomerase activity detected in these people. Telomere length was significantly decreased when compared to non-immune renal nephritis. So it's not the nephritis that causes the telomere length. It's something prior to that. Sarcoidosis, again, more frequent telomere erosion seen. Systemic sclerosis, telomere erosion was seen in both diseased patients and in their healthy relatives. Telomere activity was decreased or identical to the non-relatives. This suggests a possible role of the system alteration in combination with environmental factors and or genetic predisposition to these diseases. Juvenile idiopathic arthritis, again, we're seeing shorter telomere lengths, suggesting an inappropriate senescence of their T cells. Going on to myositis, telomeres from primary muscle cells showed a decreased proliferation rate of these cells, and therefore, again, an early exhaustion of muscle cell proliferative activity and capacity. Their telomeres also were shortened, again indicating an impaired regenerative capacity. Lymphocytes from patients with atopic dermatitis and psoriasis revealed telomere erosion again and increased telomere activity in memory T cells.